Afternoon. My name is Jordan Frey. Thank you. My name is Jordan Frank, and I'm a project coordinator at the Erie County Office of Harm Reduction within the Department of Health. We're so lucky today to have some of our partners from the U of L School of Pharmacy presenting. So I would like to introduce Julia Vicarati. She is a PharmD and MPH and a clinical assistant professor at the U of L University School of Pharmacy and a pharmacist at Vital Pharmacy. Her work focuses on utilizing community pharmacists to improve public health and access to preventative care. Alyssa Wozniak is a PharmD board certified pharmacy specialist and serves as an assistant dean for clinical affairs and outreach at the DeUville University School of Pharmacy, where she leads community-based clinical services, public health and outreach initiatives, and pharmacy provider collaborations across Western New York through their on-campus pharmacy, Vital Pharmacy. So please give a warm welcome to our lovely presenters today who are going to share some information, about one of their recent studies.
All right. Hello, everyone. Thank you for that introduction. So I'm going to just introduce where we're going today, and then I'll pass it off to my colleague to kick us off in the presentation. So my name's Alyssa, and what we're going to be presenting on today is a study that we did. So we looked at naloxone access in Erie County, specifically in the pharmacies in the county. And we'd like to present those findings from our secret shopper study today. And then with that said, I'm going to pass it over to Julia to kick us off to start the presentation.
Perfect. All right. Good morning. My name is Julia. I just kind of want us to start today by considering some situations. So imagine a community member might go into their local pharmacy to pick up naloxone for a loved one. So maybe it's their parent, a child, even a friend or a sibling who they are concerned might overdose. This person looks all over the pharmacy and can't find any on the shelf anywhere. They decide to ask a front end staff member if they know where it's kept. Unfortunately, that staff member isn't aware that this particular pharmacy keeps their naloxone behind the counter in the pharmacy where it's available for over-the-counter purchase. So the community member leaves the pharmacy feeling a little frustrated and defeated without naloxone, not because it wasn't available, but because the workflow within the pharmacy failed. Now imagine a different pharmacy, maybe it's down the street from the first one. A different community member is looking for something to help with their cold. They have some sniffles, but they notice naloxone on the shelf next to it, and they decide to purchase them because they have a family member who is at risk of overdose, who's going to be visiting for the holidays, and they want to be prepared just in case. They bring that up to the register, only to find that the naloxone would cost $50, which is more than they can afford to spend right now. There was no signage, and the cashier didn't mention that they could have taken that back to the pharmacy and had it paid through for their insurance, or that the NCAP program could reduce any copay that they may have faced. So instead, they just put it back, and then they leave the pharmacy without the naloxone. So these types of situations, which happen all too often, are exactly why we decided to conduct this study. So as we know, naloxone is now available over the counter in pharmacies, so people are able to buy it without a prescription, just like they would do with like Tylenol or cough syrup. But the retail cost for naloxone is typically around $40 to $50, which can be just out of reach for people, especially for something that they hope to never have to use. That being said, in New York State, naloxone is also available through the pharmacy under a statewide standing order. So essentially all that means is that a patient can get naloxone through the pharmacy without having an individual specific prescription from their doctor. And that would allow them to bill their insurance for the naloxone instead of having to pay for it out of pocket. And then if they have a copay, the NCAP program, which is the Naloxone Copay Assistance Program, can be used on top of their insurance to reduce that copay further. And then, of course, just like always, there is the option for prescribers to write individual prescriptions for patients billed through their insurance, just like we saw. So there are kind of multiple different pathways for a person to get naloxone, but there's been quite a bit of research in this area in other states that show that there's still gaps in access. So, for example, despite a standing order being in place, there were some pharmacies that still didn't offer naloxone without a prescription as just a policy, or if naloxone was provided, patients weren't adequately counseled on when and how to use it, There was also some noted access differences between different pharmacy types and their geographic settings. So independent versus chain pharmacies, rural versus urban settings. We talked a little bit about this already, but there was often high out-of-pocket costs for those who didn't have insurance or who weren't using insurance. And there were multiple examples of individuals that faced stigma and just pharmacy staff having workflow barriers to properly addressing this. So there's been a lot of research done, but we specifically wanted to look at Erie County specific data where there's been kind of a gap in the research. We wanted to understand the real world pharmacy experience to help to guide those future improvements in overdose prevention practices and countywide harm reduction efforts. So to do this, we conducted a study using secret shopper methodology. So we surveyed 65 different pharmacies here in Erie County, which is about 62% of the pharmacies in the county. We visited all different types, so including chain pharmacies, so things like your Walgreens, CVS, independents, which are just like mom and pop type pharmacies, and then grocery pharmacies, so like those inside Wegmans and Tops. These pharmacies were located across Erie County in urban, suburban, rural communities. And at each pharmacy, we assessed the availability of naloxone, the cost, both what it would be over the counter and through their insurance. And then we looked at whether pharmacy staff used the statewide standing order or NCAP, where they kept the naloxone. So, was it behind the counter? Was it over the counter? Or if the pharmacy would only dispense it with a prescription. We also evaluated staff knowledge and attitudes, if medication was provided and if it was appropriate given the requirements of the standing order, and just overall any staff behaviors that may have helped or hindered patients' access to naloxone. And then last thing we analyzed was the differences that existed between pharmacy type, where they were located, and their proximity to the overdose hotspots in Erie County. So what did we find? That naloxone availability is high, but access is not so simple. So 89% of the pharmacies we visited had naloxone available, and we found that availability actually did increase with the community need. So pharmacies were more likely to have naloxone available if they were located in an overdose hotspot, which is great. Like that shows that there is an alignment between overdose burden and pharmacy stocking. But there were still barriers that might make accessing naloxone, even if it is available, a little more tricky. So we found that a lot of pharmacy staff is misinformed on things like prescription requirements, the fact that it no longer requires a prescription, and NCAP eligibility. And there were multiple instances where pharmacy staff insisted that they were unable to dispense naloxone without a prescription. We also noticed some inconsistencies in pharmacy workflows, which can just make it challenging for patients to navigate. There was a lot of variation in where naloxone is kept and how a patient would need to request it, whether that be at the pharmacy at the front end, and how they would go about it. And then lastly, a lot of pharmacies kept naloxone behind the counter, so it is still available to purchase without a prescription. It's just kept in the pharmacy space. A patient would still need to ask pharmacy staff to get it for them, which just adds another layer of stigma and potential confusion, just another barrier. So even with this high availability, people will often still leave the pharmacy without naloxone because the process to obtain it can be unclear, inconsistent, or even uncomfortable. Okay, so this kind of ties into our last point, but just because naloxone is considered an over-the-counter medication doesn't necessarily mean that pharmacies are stocking it over the counter. So only about 31% of the pharmacies we visited actually kept naloxone like on the shelf where patients could pick it up themselves. This was especially pronounced in independent pharmacies where only 7% kept their naloxone over the counter. So also, even if it's kept there, that doesn't necessarily equate to access. So when it's purchased as an over-the-counter medication, we can't bill it through their insurance, we can't use NCAP to reduce the cost, and patients would have to pay that full retail price, which, as we said, is typically between $40 to $50, which can be quite expensive and out of reach for a lot of patients. And just kind of all of this to say, we found that over-the-counter availability does exist, like policy-wise, but that doesn't necessarily translate to practice, let alone actual availability for patients. And the different ways that pharmacies stock naloxone creates various financial and operational barriers for patients. So speaking of those operational barriers, we found that our secret shoppers reported a greater level of difficulty navigating the process of obtaining naloxone at those independent pharmacies compared to the chain or grocery pharmacies. So if you remember, the independent pharmacies were significantly more likely to keep naloxone behind the counter, which, as we discussed, just creates extra barriers, extra steps, and introduces the potential for more stigma. And just overall, another barrier to accessing naloxone. Interestingly, I thought independent pharmacies were also more often located in areas with a higher burden of overdose deaths, which further amplifies kind of those inequities. So all of this to say, improving processes at these independent pharmacies really has the potential to meaningfully expand access to naloxone where it's needed most. And then we found that geography shapes access. So suburban pharmacies, regardless of the type, offered more consistent naloxone availability compared to rural and urban areas who tended to have a little bit more variability in their stock. I think this just kind of goes to show how the zip code a pharmacy is located in can have an impact on whether or not a person is able to obtain naloxone or if they have to leave the pharmacy without it. Okay, I will now pass it over to Alyssa, who will go through the rest of our findings.
All right, thank you for that, Julia. So just to detail some additional findings, and then we'll get into more of a discussion here. Our fifth finding was related to that naloxone copay assistance program, or NCAP. So if you're unfamiliar with what NCAP is, it's a program run by New York State. Again, like Julia mentioned, it covers about 40% or $40, excuse me, of a copay for somebody's naloxone or Narcan, provided it is billed to their insurance in the first place. So it kind of picks up the extra. For example, if you had a coupon card for a medication in the pharmacy, but they ran it to your insurance first, it helps pick up some of that extra. All right, so with that said, that's a great thing. That's a great program for our patients. But when we secret shop this, only 4% of our pharmacies actually mentioned NCAP at the counter. So meaning that somebody showed up, they brought the Narcan there, asked for it at the counter, and they were like, oh, hey, I'll bill this to your insurance, let me build it to naloxone, or to NCAP, excuse me. So that only happened 4% of the time. Some other pharmacies were able to kind of talk about this with our secret shoppers. Once we prompted them, we gave them a flyer and said, if they don't mention it, show them this flyer, see if it rings a bell, if it's something that they're going to use in the pharmacy. So once we did that, there was an additional 36% that were able to give a little bit of information, talk about it. It doesn't necessarily mean they even billed it. We only had a couple pharmacies where they tried to bill it to NCAP. But regardless of that, 60% still were unable to, give any information about NCAP or take it farther to the billing stage. So this was a common source of confusion for our pharmacies that the secret shoppers noted. A lot of pharmacies told them the products they have on hand are not eligible for NCAP. When we talked to New York State, it's actually supposed to be that everything covered under the standing order that pharmacies signed on to is covered. So there's a little bit of a mismatch there. And then also, they didn't know, is their pharmacy eligible to enroll? Is their pharmacy enrolled? So we investigated this a little bit further. NCAP enrollment does lapse for pharmacies after a year of inactivity. And so folks might not know they're not signed up and kind of contribute to that confusion. And that said, we went through the enrollment process as a test. The information that you need to re-enroll is not necessarily readily available to most of your pharmacists that are working a day-to-day shift. Some of it is, but not always. So that said, while you can kind of sign up on the spot, pharmacies may not be able to because they won't have all the numbers basically that are needed to do so. So the impact of this is, of course, that our eligible patients will either leave with a higher copay than they would have had if they were run through this program, or pay out of pocket, or just leave without naloxone. When really this is a program that's supposed to be, in our pharmacies helping our patients. Speaking to that a little bit more, I mentioned NCAP is something that we use when we bill it to insurance, this Narcan or naloxone. In order to do that, of course, we can have a prescription sent by the provider. We'll fill it just like anything else, your amoxicillin, for example. But also, as long as your pharmacy is signed up or signed on to a standing order, which Julia mentioned, just allows you to dispense it without a prescription as part of a public health matter, basically. Not unlike we do with flu shots, a similar process, right? You can just show up to the pharmacy and get what you came for. It's a flu shot. It's a similar process. So when we looked at that standing order a little bit further, we read some of the things that are required for pharmacists to do when they're signed on to that standing order, and one of them has to do with counseling. So there are several things that our pharmacists should be educating on, what naloxone is, a little bit about how it works so that patients know it's safe, even if it doesn't happen to be naloxone, it's not an overdose that they're experiencing, so they know it's still safe to try, those kinds of things. Risk factors for overdose, signs of overdose, how to respond, calling 911, and then how to access further treatment and support. So those are things that our standing order does require us to counsel on. But that said, for the most part, our pharmacies were only giving a brief explanation. I could get into a whole host of reasons that this could be, from being busy to all sorts of things, right? So of course, there's several reasons this could have occurred. But what we observed then in practice is our counseling really just looked at device use. So 96% of the time, we did tell our patients how to use it, which is great. So we talked about how to insert the nasal spray, how to deploy it, all of that. So that's good. But really rarely did we cover recognizing an overdose, the importance of calling 911. So that was 39% and 21% respectively. And then when we get into risk factors, response steps, information to connect them to treatment and support, that was really rarely addressed. So while our secret shoppers did perceive our pharmacy staff, whoever they talked to, whether it was technicians, front-end staff, or pharmacists, as knowledgeable, we did have a good performance there, and they were also perceived as professional or supportive. We did see kind of these gaps in consistency in counseling, which the standing order does require. So that's something to note, because our patients or clients, whoever they may be leaving without all of the knowledge that's needed to safely respond in an emergency and really use that naloxone to its best capability. And also, to kind of go along with that, if somebody's purchasing this over the counter, unless there is flyers situated there, maybe a QR code to a video about how to use it, unless they read the packaging insert in that over-the-counter medication like you would for Tylenol, for example, the drug facts box, unless they do those things or bring it back to the pharmacy and say, hey, how do I use this? And you buy something over the counter, they're not going to get that counseling, right? Just how you can walk into Walgreens, buy Tylenol, and go on your way. So that OTC pathway, while really good for access, can remove some of that education opportunity as well. So we thought, perhaps this means there is a need for some simple, practical, standardized counseling tools in pharmacies. Can we put them over the counter? Can we put them back in the pharmacy counter, hand them out with naloxone, things like that? Because whatever the reason is, the counseling isn't happening. And then kind of to wrap up the last couple findings here, another thing that we found, which was interesting, is that different factors within our pharmacies is actually associated with some of our overdose outcomes in the neighborhood, which are really just going to speak to, like we all know, why it's important to have other access barriers. And I saw in the chat somebody mentioned, hey, in our county, we have this program. Great. So some of these pharmacy operation characteristics are going to just reinforce why those are important. So we did find things like hours of operation. So for example, whether pharmacies are open on the weekend, whether they're open on Sundays, whether they sell naloxone online. We know chains probably sell naloxone online, right? Like I can go to Walgreens, buy anything online. If I go to my mom and pop, they probably don't even have a website, so I can't do that, right? And then pharmacy type, so independence versus chain versus grocery. We found that those characteristics were actually associated with the higher overdose death zip codes as well. So our communities with those limited pharmacy access points, whether it was online access, whether it was open on Sundays, things like that, they tended to have higher overdose burden, which just speaks to we need these other alternate pathways as well, since we can't mandate, those operational things for all the pharmacies. So all these other programs we have, from the county or from these other programs in your community to access naloxone are obviously huge and a really big need. And then our last couple of findings here are related to just kind of that cost barrier, just to speak to that a little bit more. We actually see cost barriers that affect both patients and the pharmacies. So like we kind of mentioned, with our prescription, where we run naloxone either through a standing order or through a prescription for a patient, we can then bill their insurance and we can bill NCAP. When we have a prescription, we can do that, but if you don't have insurance, well, then you're still subject to that full cash cost. NCAP can't cover those folks because NCAP is only a secondary payer. If we try to run the full thing to NCAP, it rejects. We can't cover anything for those patients. So basically, they're left with over-the-counter naloxone costs, our uninsured or maybe underinsured patients. So that said, that's a big coverage gap in our community. And then In addition, we did see some cost variations across our different pharmacies. So our grocery pharmacies tended to be a little bit more expensive, maybe closer to the $60 range. Independents did tend to have lower pricing. That was significant across the pharmacy type. So that's something to consider if your patient's outsourcing naloxone in the community and looking to keep that on hand when we're talking about that OTC cost. And it could help with those folks that are maybe uninsured. That said, looking at the pharmacy side of things and some of the cost barriers for pharmacy, pharmacies actually lose money on insurance reimbursement for naloxone depending on the payer. So we tried to run some test claims to our pharmacy. We actually found that we lost about $15 when we tried to provide somebody with naloxone. Which, you know, when we have prescriptions for things, we're going to give it to the patient no matter what, whether we take a loss or not, right? But when you think about that, it's really a broader systemic problem, but it could potentially discourage like this broad stocking, the proactive naloxone effort. So you might think, hey, you know, dispense naloxone with everybody on an opioid, right? If we're not seeing this, this could be a barrier to something like that, because if you lose $15 a lot of times, it could become a problem. So the implication of all this is that our uninsured folks may need some alternative access points, which we do have some programming for that in the community, which is great. And then pharmacies may need some of that financial operational support to kind of sustain access and lobby for some of that systemic fix that we need to see. But kind of wrapping this up, just to think about, you know, how can we improve access together? I'm sure there's things we're already doing, so we're going to get kind of through these points, and then we'll open it up to just a last little bit of discussion here where I'm sure we're going to brainstorm some other good things. But before we kind of get to that, these are just some thoughts that we had kind of looking at this. So we thought, you know, what could community-facing providers do to maybe assist with some of this? And we thought maybe one important thing would just be helping to improve our navigation for clients. So we do a lot of social need work in our pharmacy, where we figure out, you know, do people need access to food? Do people need access to housing? Whatever it is. So we kind of keep a resource notebook of like where to quickly refer people. We thought, well, maybe one thing we could do is in your areas for the clients you're serving, for the patients that you're serving, just knowing, you know, where they can easily access naloxone. You know, so-and-so always says they can get it at this pharmacy, no problem. We could help provide some of that data, right? So if you kind of know that, it might be easy to help point somebody in the right direction. Or give options, of course, because we're talking about, you know, referring patients to different places, and with pharmacies, you have to give different options, just like you would with any care. But then also teaching clients and community members kind of what to expect at the pharmacy. So if you say, hey, you know, go pick up naloxone at the pharmacy, not necessarily that easy. So where do they look? They can look over the counter, but if they do, they're going to have to pay $40 to $60. So if they don't want to, bring it back to the pharmacy counter, ask to bill insurance, and also ask to bill NCAP. So these are just some quick things that we can teach patients. Or if they come back to you and they say, yeah, I tried to get naloxone, I thought I needed it, pharmacy didn't have it. Well, it's not that simple, so maybe we can just provide some quick counseling, and we'll have some handouts that will be shared with you just to kind of go through that. So kind of helping clients overcome these real world barriers might be nice. So just coaching your clients, you know, ask the pharmacy to run the naloxone through the standing order if they can't find it OTC. If they have a high copay, ask them to bill it through insurance, ask to bill through NCAP. And then if you see access barriers and you see a trend, I'm not sure where we should report it, but we probably should so that we can coordinate solutions, because that's kind of what we found here, is that there are barriers and we need to work to fix them. We'll also get a little bit into what we think we could do to assist, but other than that, we also just thought of maybe strengthening our community pathways. So if you already keep resource lists for certain things, maybe social needs, for example, keep a resource list maybe for naloxone. Where can they easily get naloxone? And you probably already do, right? You probably have your program that gives naloxone through the county or whatnot. But if there's a couple pharmacies in your area where they could get it easily, you know, toss those on as well. So kind of just supporting those awareness efforts to teach somebody, you know, where can I go to get naloxone? And then as far as clinicians and prescribers, we thought, you know, what could we do to make pharmacy pickup easier for patients? We thought, I guess you could consider prescribing naloxone even though it is OTC and even though we have the standing order. Why? Well, sometimes pharmacies are not signed up for the standing order. Sometimes their standing order enrollment has lapsed. Sometimes they need to re-enroll in other things. But if you send a prescription every time, it removes all those barriers. Of course, that's clicks on your end. But maybe your EMR has like a setup where you can send that as a bundle with an opioid. I don't know. But those are just some ideas that we had, because that then avoids issues with pharmacies not being under the standing order, not knowing what to do. And sometimes it just depends who you talk to at the pharmacy and whether they know how to direct you the right way, which is unfortunate. But and if you have the time when you're working with your patients, just a brief counseling moment, any little point that you can relay will help ensure that they get additional counseling on how to use it, whatever it is, on top of whatever the pharmacy can provide. So all that would support any pharmacy workload. You can always encourage your patients, like the pharmacist should tell you how to use this. If they don't, ask. A lot of times our patients come to the counter, any questions? Nope. But encourage them, talk to the pharmacist, make sure they tell you how to use it. This is why it's important, so that they know that that's a resource for them. And then also telling them about the NCAP program. If you have a flyer on hand about NCAP, give them that, because the pharmacy may not know what they're talking about otherwise, and it'll save them $40, which is great. And then also, same thing, if you have an issue, prescriber with a certain pharmacy, every time you send naloxone there, it's a problem. Patients met with stigma, whatever it is, they never fill it, it's never in stock. Somehow report that so we can, address that at a system level. And then lastly, I think at a county level or systems agency type level, just thinking about, well, how do we address those pharmacy level gaps? Obviously, we need to reinforce our standing order requirements with our pharmacies and talk about those counseling things that need to be covered. Maybe consider providing them some educational materials. New York State does have a birth control access program where pharmacists prescribe under a standing order. And one thing that's nice about that program is all the birth control counseling is like there. You just give it to your patient. So perhaps we could do something like that with naloxone or Narcan. And some of that probably exists. It may just not have made it to every pharmacy, right? So that's all good things. And then also NCAP. We maybe have a new NCAP re-enrollment strategy. Let's get all our pharmacies back re-enrolled if it fell off and you didn't know, things like that. And then lastly, encouraging our pharmacies to publicly display where is naloxone available in your store. Is it just over the counter? Is it just behind the counter? That way they don't leave. Couldn't find it, I left, so it can help. That visibility can help with some of that navigation. And then also we found we need more support in our independent pharmacies and then our rural and urban hotspots where we found some pockets. So we have wall boxes, vending machines, all of that. So just making sure they're in those hotspots, and I'm sure they are. So those are all great things. Maybe we can have a countywide naloxone access map. The state has one, but there's some holes in that one. Not everybody in Erie County was there. So maybe we could have something like that, which would be great. And maybe we can advocate for NCAP, increase. So what do we do for those uninsured patients? Can we give them $40 even though they're uninsured too, right? Does it have to go through insurance first? So just some things to think about from an advocacy standpoint that could help. I'm sure there's barriers to all of these things and people have tried, but just to mention. So kind of in conclusion, we did find that naloxone varies widely by pharmacy type, zip code, and then major gaps in our independent, rural, and then some urban hotspot pocket areas. And that was mostly related to standing order confusion and NCAP use. So while naloxone or Narcan was available, these things actually made the process harder and things like that for our patients. So we would love to partner with whether it's Erie County, New York State. We've talked to New York State a little bit about their NCAP program already to kind of strengthen these pharmacy workflows, put a big push back into the pharmacies to make this another focus again. So we would love to assist with some of that, and we think it's important as well. But we'd love to know, how can we help your organization? What are you seeing in the community? How do you think pharmacies could help? Things like that. So we know that improving access in pharmacies, it's a pharmacy problem, but multi-sector collaboration helps, because while I know the pharmacy world, you might find something all the time when your patient tries a naloxone, and I don't know about it. So if we could share that here today, I think that that's a good thing. So with that said, that's kind of where I was going to conclude the presentation. So our contact information is here, but yeah, just, what can we help with further, or what are you seeing in the community if we have time for discussion?
I think we can give folks a couple minutes to see if there's any lingering questions or thoughts. There is someone who mentioned something about wondering how effective education or counseling coming from pharmacists who seem to be operating with a large negative bias might be, and if this would pose a larger deterrent than it would be helpful, which I think is interesting to think about, and if you guys have any thoughts on that. But if anyone else has Additional thoughts or questions, please feel free to add them into the chat before we move on to Erie County data.
Yeah. Let me just make sure I understand the question. So the question is, I'm sure I could probably find it in the chat, but it's related to if somebody does have a negative bias, perhaps, and they end up providing more counseling, would that help or hinder? Is that kind of the question? I'm just digging through.
Yeah,
Yeah.
it's essentially saying like if the pharmacist is coming
Okay.
with a negative lens to
Yeah.
counseling that individual, is that going to help or hurt the situation?
That's a good question. I'll offer my thoughts, then I'll turn it over to Julia if you have any others. So I guess the good news is when we looked at our pharmacy, looking at the sort of attitude and behaviors of the pharmacy, like did you feel stigma, things like that. I think it was like 80%. Everybody kind of in that said no, but we did still have a small percentage that maybe they felt a little bit, judged or like there was stigma or, things like that. So there is still a little bit for that potential in our pharmacist population. It could also depend who they talk to. So I guess I shouldn't say just pharmacists. It could be, front end, but regardless, it's happening in pharmacies. So yeah, I think you raised a good question because there is potential for that given we did see that percentage. There was no differences across pharmacies or geography or anything like that. But I guess for that reason, that's why I'm thinking if we can provide some standardized information, kind of like we do with our birth control prescribing program, it could help with that. Because that one, it's prescriptive. It's like you give the patient this and you tell them this, and here's all the information that they need about how to use that particular birth control, for example. So I think that kind of could help if it was included with that standing order. And then in addition, when people sign on to those standing orders, they usually are doing that because they want to improve access to the patient. So I think that's probably why we do see pretty much a good performance in that category. But yeah, there was a small percentage where we did see a little bit of potential for that. But I'll turn over to Julia in case you have other thoughts on that matter.
Yeah, so it's kind of building off of that. I do think what we saw was that most pharmacists were at least like supportive or neutral, which is a good thing. But I know just to kind of continue to, I guess, bridge that gap in like knowledge and empathy and understanding. I know like with our flu shot standing order, we all have to attend like a continuing education before the standing order goes into effect. So I don't know why we couldn't do something similar, but more focused on like coming at it from like the stigma and like opioid use disorder as like a disease, not as like a character flaw, like those types of interventions, just as an education standpoint, just to make sure we're all on the same page.
That's great. Thank you.
Let's see. Stacy said, as a care coordinator, it would be helpful to have seminars available to explain mental health medication, especially, and also symptoms to look out for, such as hallucinations that happened with a client med change recently. Oh, yeah, psych meds. That's a whole different world. Yes, I love the concept of like, I don't even know, a lunch and learn about meds.
Yeah, I think that could be great. And a lot of times those things go hand in hand even with a topic like this. So
it all ties together.
Yeah, we do see that frequently in pharmacy, certainly a high need population. So I agree there's a need. Asthma inhalers and albuterol vials can have milk proteins. I'm curious about this as clients with dairy allergies who have asthma. Yeah, we can I don't know if you want to put your email in the chat or directly to us. We can kind of look into that and provide you some information if you're interested, Stacy. You can send it to me or Julia and we can follow up with you. We do know other pharmacy things, so we're happy to share if you do have other questions. Okay, I'll take that down. We'll connect with you.
It looks like that's it. Did anyone else have any other additional questions or things that came up during the presentation?
And then I will note, we put together just like a quick how-to for that process of where people can find naloxone over the counter or whether it's behind the counter, the questions to ask about their insurance. So we put together a version that is, I guess, more provider facing or community worker facing that you could kind of take a look at to help your patients know what to ask. And then we also put together one that you can hand out to your patients. So I saw somebody posted that those will be shared out to you. So you can look out for that as well if there's a need for that in your population.
Thank you so much, Alyssa and Julia. This was incredibly helpful. Local data in regards to naloxone access, I mean, local data in general in public health is always superior. So I'm very excited to learn. I was very excited to learn about this. Thank you so much for sharing. Feel free to reach out if you have any additional questions, and we will definitely be sharing all of that information that Alyssa and Julia spoke about in the newsletter. Next up, we have our data analyst, Jason, to share some updates and data.
Yes, first of all, can everybody hear me okay?
We can hear you, Jason.
Great. And are the slides coming up?
They are.
Okay, awesome. You just enter presentation mode. All right, so welcome. That was an incredible presentation, a lot of great research there from the UVille, and hope to see lots more studies like that. So for this month, we're going to start with going over the overall overdose death picture. Then we're going to compare to the statewide trends. We're going to look at overdose death demographics, overdose death toxicology, and then new for this month, we're going to be doing a deep dive on opioid-related death toxicology, looking at what else besides fentanyl is in the drug supply. Then we're going to be looking at overdose deaths by zip code, our non-fatal overdose reporting frequency, non-fatal overdose locations, and then a comparison of the locations of non-fatal versus fatal overdoses. So in 2025 so far, with cases reported through December 11th, we have 224 overdose deaths in Erie County for the year. 155 are suspected to be opioid related. 133 are confirmed opioid related, and 22 are still waiting for toxicology. And 69 are confirmed to be non-opioid related. So once again, we are still looking at most likely coming in at under 250 for the year, with the year almost being over. So we're on par for another substantial decrease year over year from 2024. Comparing the statewide trends, this is looking at the number of overdose deaths that have occurred in the past 12 months from each respective month. So for the 12-month period from December 2024 through November 2025, we experienced 234 overdose deaths, which is a 36% decrease to the 12-month period prior, ending in November 2024. We have not yet received new New York State CDC data, but with the most recent data available, which was as of April, New York State was at a 37% decrease. So our current decrease is right around that level. And it looks like we are approaching levels of overdose deaths that we haven't seen since pre-pandemic. So around 2018, 2019, we're at about those levels as of right now. So positive signs. Looking at our overdose death demographics, you can see the Black population is still disproportionately affected by overdose deaths, although the disparity is beginning to shrink. August 2023 to July 2024, which is the orange bar, that was the peak of the disparity, where we saw 35% of our overdose deaths as part of the Black community. And in the most recent 12 months, which is the red bar, our overdose deaths have been 23% Black. So there's still a significant disparity that exists, but it is happening closing each month. Now we're going to look at the population-adjusted demographics by race and ethnicity. Population adjustment allows us to see these disparities a little better and monitor them over time. And this is going to show which groups are most disproportionately affected. The bigger the gap between these lines, the bigger the disparity is. And as we mentioned, the disparity was largest in mid-2024, 2023 into 2024, but it has been closing rapidly. And in recent data, we see the Hispanic population is now the most disproportionately affected by overdose deaths, ever so slightly, although the rates among the Hispanic and Black populations are at the moment very similar. It looks like the decline in overdose deaths, the decline in the disparity has started to slow down a little bit. We're not seeing as steep of a decline in recent months that we were throughout most of 2025. So we will continue to monitor that and see how those rates evolve over time. Year over year, from November of last year, among the Black population, we've seen a 54% decrease in population-adjusted deaths, a 23% decrease among the Hispanic population, and a 25% decrease among the white population. So decreases across the board, although they might be showing signs of slowing, and we'll continue to monitor. Looking at non-opioid deaths specifically, which are largely cocaine-related, we see that the racial disparities remain large despite a recent decrease. So in mid-2024, we had seen a very large spike in non-opioid deaths, population adjusted, among the Black population. And since this is looking at a 12-month average, now that those months have fallen out of that 12-month window, we're starting to see that disparity start to come down. So we have not seen, more non-opioid deaths in recent months to make up for that spike in mid-2024. We have now seen that rate of racial disparity decrease to levels we saw in like 2020, 2021. So we have significantly come down from the peak in mid-2024. And we'll continue to monitor, but it looks like we might be approaching a lower steady state of disparity. It'll be interesting to see if this continues a sharp decline or if we level out at around this current level, which is still a significant large disparity. Looking at age demographics, for overdose deaths, we can see that the 40 to 49 age group is still the most disproportionately affected. And the declines in death rate across the board seem to be slowing a bit. Interestingly, we do see somewhat of a convergence among the 50 to 59 age group and the 30 to 39 age group. The 50 to 59 age group, which is that dark gray line, is continuing a sharp decline that it has been declining rather sharply since mid-2024. Whereas among the 30 demographic in their 30s, we're seeing that decline basically stop and even uptick very slightly. So we're seeing that convergence among the 50 people in their 50s, people in their 30s, with people in their 40s remaining the most disproportionately affected. People in their 20s and younger have reached all-time lows regarding population-adjusted overdose deaths, and the 60 and older demographics, so older adults, is starting to slow as well. So looking at the overdose death demographics by age in a slightly different way, here we're looking at each age bracket and the percentage of each age bracket that is confirmed non-opioid related versus opioid related. So we can see that for the 50 to 59 and the 60 and older age groups, upwards of 40% of those age demographics were non-opioid related deaths. Whereas for 40 to 49 and younger, it's 25% or less. So there is a pretty stark difference in the age profile, or rather in the substance profile, when we look by age. So we can see a very strong difference there, which we'll look at in some more detail here. This is looking at those population-adjusted deaths over time by age, and this is specifically for non-opioid deaths. And we can see that 50 to 59 age group, this lines up with that previous slide, that we're seeing a very high disproportionate impact among the 50 to 59 age group. It increased throughout 2024, and it has remained relatively flat in recent months, but still the largest age group by far. In contrast, we saw the 60 and older age demographic significantly decrease beginning in late 2024 and continuing to decrease in recent months. Yeah, with the 60 and older age group declining so sharply, it's really the 50 to 59 age demographic that's being predominantly affected by non-opioid related deaths. Looking at our overall toxicology in the past 12 months with data available through September 2025, we can see that opioids and cocaine, both being detected in conjunction, have decreased significantly over time. At the peak of our overdose deaths in 2023, 58% of our deaths were related to both opioids and cocaine, and now that's down to 37%. Another 30% is opioids only, which is up from 25% in 2023. And we have seen an increase in cocaine only, where it was cocaine only in the absence of opioids were 13% of our overdose deaths in 2023, compared to 21% in the most recent data. Looking at this over time, so this is basically that same pie chart, but stretched over time. The pie chart's like a snapshot, and these line charts show how each slice of the pie has changed over time. So this allows us to see recent trends more clearly, and each point is an average over the past 6 months. So we can analyze these trends and see what has changed. So in the most recent month of data that we've incorporated here, which is September of 2025, we saw an increase in both opioids and cocaine deaths. So that's the blue line, both opioids and cocaine being detected. That's now close to 40% of our overdose deaths. In contrast, we saw a decrease in opioids without cocaine. So opioids without cocaine decreased to 27% of our overdose deaths. And other categories of cocaine only and other substances are remaining fairly the same. 20% of our overdose deaths were cocaine only in the absence of opioids, and 13% were other substances such as methamphetamine, benzodiazepines, and various other things. So that's a trend we'll continue to monitor to see if that opioid, both the lines of both opioids and cocaine continues to increase, or if we're going to see it drop back down again to where following the decline that we had seen through most of 2024 and 2025. So we'll continue to monitor that, but it is rather concerning that we're seeing this uptick in opioid and cocaine deaths. So now, to keep things fresh, we're going to do a deep dive into our opioid-related toxicology. So this is specifically looking at opioid-related deaths and their composition. So in 2025 data, we can see that as a percentage of opioid-related deaths, fentanyl decreased rather significantly, and other opioids increased pretty significantly, while heroin fell to an all-time low. It's important to remember while we're looking at these opioid-related data that the majority of our opioid-related deaths involve 2 or more substances, often fentanyl, but even within that other opioid category, we'll often see multiple different opioids being detected. So it's important to keep in mind that these categories often overlap. In 2024, we saw 238 fentanyl-related deaths compared to 101 in 2025 year to date. And just once again, data for 2025 is not yet complete, but we are getting close. And when we're looking at that other opioid category, we saw 33 in 2024 and about 30 in 2025 year to date. So it's not so much that the other opioid deaths are going up. This is more a product of the fentanyl-related deaths going down. So as the fentanyl-related deaths go down, the other opioids are making up a bigger portion of the pie. So now we'll look at that in a little more detail. So looking at deaths, opioid-related deaths, excluding those that are related to fentanyl, we see similar rates of buprenorphine, methadone, oxycodone, and hydrocodone. Each one had about 7 or 8 detections among all the overdose deaths, with a good degree of overlap. And excluding fentanyl, we see very, very little tramadol or heroin. We can see that orange line is heroin detections, and since roughly 2022, heroin's been almost non-existent in our drug supply or among overdose deaths in the deaths that exclude fentanyl. When we look at deaths that include fentanyl, that will go up slightly, but yes, we'll examine that. Looking at deaths including fentanyl, we see more deaths from all these other opioids, indicating that a lot of these deaths that were related to other opioids also involve fentanyl. And in particular, we still see an increased frequency of methadone and tramadol compared to the non-fentanyl deaths. So as we mentioned in the previous slide, tramadol was almost non-existent among the opioid-related deaths, excluding fentanyl. But when we include fentanyl, we see quite a few more tramadol deaths, as well as methadone deaths. However, for the other opioid substances, buprenorphine, oxycodone, and hydrocodone, we don't see a lot of those related to fentanyl. Those figures are roughly the same whether we look at the deaths that include or exclude fentanyl, indicating that most of them do not include fentanyl. I had to remove the heroin line from this graph because when we include the fentanyl-related deaths, it actually would go off this particular chart. So we'll look at that on the following slide. But for quite a few years, the vast majority of our heroin deaths also involve fentanyl. So now if we add in fentanyl, I changed this to a bar chart to make it a little easier to visualize. Fentanyl still accounts for the vast majority of opioid-related deaths. But on a positive note, our fentanyl-related deaths have decreased dramatically from 2023 to 2025. In 2023, we saw upwards of 300 deaths related to fentanyl, and in recent data, it's looking at right around 100, a little over 100. So very significant decrease in fentanyl-related deaths. We can see heroin-related deaths have also become practically non-existent, and all the other opioids are basically dwarfed by fentanyl. Interestingly, if we exclude cocaine-related deaths, because as we mentioned in our toxicology slides, many deaths are related to both opioids and cocaine. But if we exclude those cocaine-related deaths, we can see fentanyl-related deaths have been decreasing continuously since 2021. Now we in the absence of cocaine, we have less than 40 deaths that are related to fentanyl in total. So a lot of the fentanyl-related deaths that we're still seeing are also related to cocaine. So that was our deep dive on toxicology. I hope that you found that interesting. Now moving on to overdose deaths by zip code in the past 6 months, from June 2025 to November 2025. The most disproportionately affected zip code was 14215 on the east side, which borders Cheektowaga. There we saw 10 deaths. Next, we saw 14201, which is on the lower west side, where we had 7 deaths. 14212, which is near Broadway on the east side, also 7 deaths. And then 6 deaths in South Buffalo, 6 deaths in Hamburg, 5 deaths in Lackawanna, and 5 deaths in West Seneca. Lackawanna is a new one. We hadn't seen a lot of too many deaths there in quite a while. So this is the first time in a good amount of time that we've seen Lackawanna cross that threshold of 5 deaths. So that's something we'll continue to monitor. But yes, as overdose deaths decrease, there's going to be fewer and fewer zip codes that are going to meet that threshold of 5 deaths in this 6-month span. So it'll be easier to focus on individual locations to reduce those deaths further. Looking at comparisons over time, we're seeing, so on the left, we have the 6-month window from December 2024 to May 2025. On the right, the one we just looked at, June 2025 to November 2025. Areas where we're seeing increasing overdose deaths include 14215 on the east side, 14212 near Broadway, 14218, which is Lackawanna, and Hamburg, which is 14075. Areas where we're seeing decreasing overdose deaths include 14207. That's the Black Rock Riverside area. And that is particularly notable because the Black Rock area is where we see a very high concentration of our overall overdose reporting, and usually our highest concentration of deaths. So the fact that we're seeing significantly fewer there is a really positive sign, and is quite unexpected. 14211 is also on the east side of Buffalo near Genesee Street. There we also saw a decrease in death. And 14203, which is a strange one because that's a zip code where not a lot of people actually live. It's south of downtown Buffalo, kind of in the outer harbor area. And we saw a decrease in overdose deaths there. Now looking over at our non-fatal overdose reporting, which is compiled for us by our local HIDA office. And we thank them very much, as always, for the diligent work they do in collecting these reports and sending them over to us. They receive these reports daily. They aggregate them from law enforcement reports and emergency service calls, and they send them to us for overdose response and planning of outreach. It's important to note that not all overdoses are reported. There's a significant degree of underreporting, and often people will, take care of a bystander will handle the overdose, or someone else will handle it. A family member will handle it or something, and it doesn't ever end up getting reported to law enforcement. So it's important to note that this is not the full picture of overdoses in Erie County. We typically see 2 to 3 reports per day. Even though overdose deaths are down, our non-fatal reports are still in that range. In recent weeks, we've pushed towards the bottom of that range of about 2 reports per day. A few months ago, we were pushing the top of that range towards near 3 reports per day. But we're still kind of in our normal range, which is interesting considering the significantly decreased rate of overdose deaths. Looking at our shifts in non-fatal reporting over time by zip code. So we've got 6-month windows of December 2024 to May 2025 on the left, June 2025 to November 2025 on the right. And we've seen a couple of significant shifts. Most notably, I think, the Lancaster and Depew areas, which is 14043 and 14086, suburbs bordering the Cheektowaga, east of the city. There we've seen an increase in our non-fatal reporting, where they didn't meet the threshold for reporting in the previous 6-month window, but recently they have. We've also seen an increase in reporting in the Springville area of 14141, kind of a more rural zip code. And then aside from that, we saw increased reporting on the east side of Buffalo, particularly 14211 and 14215. And broadly on the west side, and including Black Rock. So that's that block of 3 that we often talk about: 14207, 14213, and 14201. So the lower west side, all the way up through Black Rock, saw increased reporting. Also, Eggertsville, the Eggertsville area within Amherst, 14226, we saw an increase in reporting there. And conversely, we saw a decrease in reporting in another area of Amherst, 14221, which is kind of the Williamsville area. So some shifting in reporting within the suburb of Amherst. We also see a decrease in reporting in Grand Island, Kenmore, and Hamburg. Hamburg is notable because we saw an increase in overdose deaths, but a decrease in non-fatal overdose reporting. So that's cause for concern that we might be seeing some underreporting going on in Hamburg. And we also saw a pretty significant decrease in 14209, which is kind of right in the center of the city of Buffalo along Main Street. So as I mentioned, we typically see more non-fatal overdose reports than overdose deaths in each zip code. And so if zip code overdose deaths exceed non-fatal reports, that's a cause for concern and a potential indicator of underreporting. So we'll look at some of those zip codes that are cause for concern. And it's most of the zip codes that we discussed in our overdose deaths by zip code. 14215 and 14212, which is the Upper East Side and near Broadway, both exhibited a disproportionate number of deaths relative to reporting. Same with West Seneca in 14224. 14224 has, in general, had a disproportionate level of overdose deaths this year. And that's something we'll be continuing to monitor. Lackawanna, as we mentioned, is also an area of concern where we haven't really seen too much reporting, but we saw a significant number of deaths. And Hamburg, pretty significantly, really not a lot of reporting, but a significant number of deaths. So just to summarize, overdose continues to decline, but non-fatal reports are holding steady. Disparities by race and ethnicity are still significant, but decreasing. They remain large for non-opioid related deaths, although we did see a significant recent decrease. The age profile of our overdose deaths differs by substance. Our for non-opioid substances, we predominantly see deaths among the 50 to 59 age group. For opioid related deaths, and overall overdose death is predominantly 40 to 49. We see a high concentration of death in the east side of Buffalo, the Lower West Side, and West Seneca. And we're seeing overdose deaths decrease in Black Rock Riverside, the East Side, particularly near Genesee Street, and the Outer Harbor south of downtown. And we're seeing more deaths than we expected in West Seneca, Hamburg, and the East Side, with Lackawanna emerging as an area of concern with a high number of deaths relative to reporting. As always, I'm going to plug my data webinars for our heat maps. If you're interested in digging a little deeper into the locations where we're seeing overdoses congregate, please join us for our quarterly webinar. And you can scan this QR code, or I'll drop the link in the chat. Our next one is in February. You can ask questions, request specific maps, and sign up for monthly heat map updates once your organization signs and returns an MOU indicating that you intend to keep the data internal. We've been sending out reports for a couple of months now, and we've got some people seem to really enjoy them. So we would love to get those out to some more people. Thank you very much.
Thank you so much, Jason. I didn't see any questions regarding Jason's presentation in the chat. I'm just going to reiterate what Lee posted. We do have a little survey now for the end of our Bridge Erie presentations. We just on how you thought the presentation went, and if you would be interested in maybe presenting at Bridge Erie at some point in the future. So we would really appreciate if anyone could fill that out. I know we all work in this public health space. Oh, there is a question, Jason.
Let me see. What are the I'm assuming that means non-opioid deaths in the older population. There is definitely some alcohol in there. Although I'm not really sure if yeah, no problem. I'm not really sure if alcohol is disproportionate among the older population. For non-opioid deaths, it is mostly cocaine across the board, and particularly in the older population. Maybe next time, instead of doing a deep dive on opioid-related deaths, we can do that deep dive on the non-opioid-related substances. But it is predominantly going to be cocaine.
Awesome, that would be helpful. It looks like, Jason. Something to consider for next month, for sure. Thank you so much for everyone coming and joining Bridge Erie this afternoon. Again, please help us out and fill out the survey, and we look forward to seeing you next month.